the Baltimore epidemiologic catchment area study, the longitudinal aging study of India, and the national health aging and trends study. His research is highly cited, particularly in the current landscape where hearing loss is gradually being recognized as a major health issue, and delivery models are evolving to increase access and affordability of what is finally being recognized as a meaningful health condition. There are really very few people nationally with as strong of an understanding of the political issues that are at play and the research strategy that is necessary to shape the future of hearing healthcare in America. Personally, I'm very fortunate to know and to have worked with Dr. Reed in more than one capacity. Very early in his career, I was his advisory committee chair when he served on the National Student Academy of Audiology Board of Directors. And more recently, we worked together as part of the Hearing Health Collaborative, which is a think tank of audiologists, otologists, public health specialists, primary care providers, and patient advocates who have been charged with developing a blueprint for changing the landscape of hearing healthcare. I personally read and cite his work on a regular basis, so I'm really looking forward to hearing Dr. Reed's presentation today and introducing the important issues that he'll present to the rest of our institute. So without further delay, I'll turn the meeting over to you, Nick.
Thanks. That was very kind of you. Appreciate it. Hopefully you didn't set the bar too high. All right, so thank you so much for having me this morning. Let me get my screen shared. I'm sorry, I'm a Zoom person, so it takes me a second on Teams to remember where everything is. Are you seeing the presenter view, or are you seeing the actual slide deck view?
Presenter view.
You're seeing presenter. So let me switch. Now you're seeing the.
No, I meant like we're getting your good. You're correct. This is good.
You were okay.
Yep, we've got your slides.
Great. So I'm going to talk this morning about some of where my work has gone really recently, and this is the foundation for my K23 award. It's really focusing in on hearing loss in the healthcare system, and I'll tell you sort of why I've pursued this line of work in a minute. Quick disclosures, I am funded by grants from the NIA and NIDCD. I'm on the scientific advisory board of Neosensory, and I am faculty at the Cochlear Center for Hearing and Public Health, which I don't take direct funds from, but I obviously do benefit from a large private gift from Cochlear, the namesake of the center. Any talk that's sort of public health facing, this audience does not need this, but I usually always start just by putting people in the right frame of context that we know a lot about hearing loss. We know hearing loss is associated with aging, but I think we often underestimate just how high the prevalence of hearing loss actually is. This is data from a nationally representative health survey and Haynes. And once you get over the age of 60 years in the United States, half of all adults have a clinically meaningful hearing loss. And honestly, if you're, we actually have a piece under review, and I wish it would just, or in press, and I wish it would just get out there so we could put the image out there more. If you use the new World Health Organization criteria, these numbers jump up drastically. They moved the bar down actually, so that the criteria for hearing loss for the 4-frequency PTA moved from 25 to 20. And we get into, almost 70% of adults over 60 having hearing loss. When we get over 80, it's almost 98% of adults in the US have a clinically meaningful hearing loss. So hearing loss, highly prevalent, highly associated with age. And at the same time, hearing aid uptake is low. You've probably seen numbers as high as 30% for hearing aid uptake in the United States among people with hearing loss. This is data from a nationally representative survey, again, and Haynes. It's asking the specific question, do you own and use a hearing aid? Have you used it in the past month? And when you use that use question here and you look at adults with hearing loss, adults over 50 with clinically meaningful hearing loss, it's actually only 16.4% report that they used that hearing aid in the past month. So that may mean ownership is slightly higher, but use may not be that high. You've seen a ton of work coming out recently where hearing loss has been the exposure in healthy aging outcomes. And it's been related to cognition and dementia. That's gotten the majority of the attention, avoiding injury, maintaining physical activity, keeping socially engaged. And then to a lesser extent, I think, but hopefully we're making a dent in this, health resource utilization. And I'll be honest that my motivation here is very personal. I was really pursuing a career where I wanted to work on over-the-counter hearing care and direct-to-consumer hearing aids, and that's not something that I've completely abandoned. But I was very happy. I was doing a lot of comparative effectiveness work, and then this is Scott Sutton. He's he's one of my best friends. And unfortunately, around the time he was 35 in 2018, he was in the hospital. Scott had von Hippel-Lindau syndrome, so he had issues with tumor suppression. He had tumors in spine, brain, lungs, throughout his body. He had a recent MI and was hospitalized at a hospital that I won't name. It's not Hopkins or Cleveland Clinic, but it is a hospital that's very famous for doing delirium research, and for being a supposed, top tier care hospital. Neurologically, Scott was normal, but as he was in the hospital, his wife had called me, and I was on my actual way to Pittsburgh, and she said he was acting different, and I didn't know what she meant, and I just assumed it was nothing. When we got there, it was very clear that he was experiencing sort of an acute delirious state and very much hypoactive delirium. Most people assume delirium is this sort of hyperactive, yelling and over sort of manic state, but that's actually not true. 95% of delirium is really withdrawn, confusion, making statements that may not make sense, but not necessarily acting, overly, outwardly confused. Recent imaging that the physicians in the hospital either were not knowledgeable of or did not, take the time to read had actually revealed that Scott had tumors pressing up against his IAC. And I remembered this from his wife telling me and him telling me. And honestly, in the hospital, I had one of my research assistants overnight some amplifiers, and that's what Scott's wearing in this picture. And when we put it on him the next morning, within hours, he started to come back to us, and was completely neurologically normal. I started engaging with his physicians again, was engaging in his healthcare again, and was there. And the last 3 months of his life following that hospitalization, Scott wore that amplifier every day. And it was a complete game changer for me in terms of just seeing how much hearing mattered, and how, even though this hospital, like I said, relatively famous and known for implementing HELP, which is the Hospital Elder Life Program, which talks a lot about hearing and delirium and vision and delirium, completely overlooked it. And I think it has a lot to do with the very nature of these programs, not necessarily thinking about sustainable models to address hearing, and I'll talk about that later. And also just sort of overlooking how much hearing really does matter. It's often sort of a forgotten component in many of these programs. And so to be totally honest with everyone on this call, I went home and I ripped up an entire K23 award and wrote a new one focusing on this conceptual framework, that hearing loss via mediators like poor treatment understanding, sensory deprivation in the hospital, communication breakdowns. And when I say stress, I don't necessarily mean psychologic stress. I also mean physiologic stress in the hospital from the communication breakdowns, resulting in things like patient safety events, delirium, length of stay, satisfaction with care changes, and then long-term outcomes like health utilization patterns and modified help-seeking behaviors. And so I'll focus in first to set the groundwork for these mediators, this idea of poor patient-provider communication and hearing loss. And this audience does not need this slide, but I usually also just share with the audience that hearing loss is an issue of most hearing loss being peripheral. It's an encoding issue where you may get the sentence, "You should go to the pharmacy before you get to your house." And when you decode that with your brain, it becomes "you would go to Arma E before you get to your oo." That's a rough back of the napkin estimate for me doing just some basic hearing loss. That's a high frequency phenomenon. But the point is that I'm often conveying, and I use this actual example with our hospital staff, it's not a volume issue, it's a clarity issue. I say the exact words at the same level, and you're just missing parts of it. And that's something that most people really don't understand. And it actually, I think, leads to worse treatment of hearing loss in the hospital and accommodations for hearing loss. So patient-provider communication is this sort of cornerstone of patient-centered care. The 2001 Institute of Medicine Crossing the Quality Chasm report pushes that it's care that is respectful of and responsive to individual patient preferences, needs, and values. And I think for hearing loss, I really key in on the word needs. But I'll be honest, in that Institute of Medicine Crossing the Quality Chasm report that's focusing on patient-provider communication, if you do a little control F, you won't find hearing loss mentioned in that entire report. You'll find plenty of other risk factors, but you won't find hearing loss even talked about. Patient-provider communication is related to healthcare outcomes. We know it's related to time to diagnosis, treatment understanding, long-term post-hospitalization outcomes. But there's relatively little work here. There's one study, and honestly, this is a research report or a research letter in JAMA Otolaryngology that interviewed 100 adults with semi-structured interviews in Ireland over 60 years of age. And you got these sort of overarching findings that hearing loss led to reports of missed consultation content and unable to understand unfamiliar language. And I've always sort of chuckled a little bit about that because what language is familiar in the healthcare setting? Even people who understand healthcare and are well versed in healthcare have no idea what other fields are talking about often. So I find it sort of interesting that they framed it that way. Most language is unfamiliar, meaning that I think most healthcare interactions would be difficult to understand. And then there's a systematic review. It's wonderful out of NYU, where they just looked at studies that had patient-provider communication as the focus in older adults. And they just looked for hearing loss in the studies. And less than a quarter even mention hearing loss. And only 6% of studies in their systematic review included hearing loss in the analysis. Our own team did a systematic review specifically focusing on patient-provider communication and inpatients. We found 13 studies, and I should always put the abstract pull up here. We pulled from 5 databases, and we pulled 3,000 papers. And we found 13 that included hearing loss somehow in their analysis. And in each of those studies, hearing loss was not only associated with poorer perceived patient-provider communication, it was often usually the strongest association and sort of a driving variable. And in qualitative work, it was often considered this sort of most important sort of barrier. And some of the emergent themes of those papers, though, were that from the provider perspective, providers felt like hearing loss contributed to poor relationships and longer treatment time and longer time to diagnosis. And when addressed in the few studies that did talk about this, patients reported perceiving better communication. So it is something that we might consider modifiable. And so if we go back to our conceptual framework, our team decided to start actually with the big picture here and get into the healthcare utilization patterns. And I think these are things that are sort of the framework that we need to lay for, as Dr. Sadlowski said, political side of if we want to change the landscape around coverage for hearing care, for example, I think putting dollar signs on some of these and healthcare utilization patterns is a very meaningful one, may suggest cost effectiveness. And, I'm not going to jump to that conclusion yet, but, it lays the groundwork. And so we started with the hypothesis that hearing loss would be associated with increased healthcare utilization and cost. We went to the Optum Labs data warehouse. At the time, there were 125 million de-identified data claims from across the US. It's something like 300 million now. Optum Labs is a warehouse that consolidates private and Medicare Advantage plan data. They have physician hospital prescription claims information from EMR from about 20 some hospital systems throughout the country. And these are major hospital systems, including Johns Hopkins and the UCSF system. They have socioeconomic and satisfaction measures, Medicare and private insurance surveys. Our analytic sample for this study was from January 1, 2000 to December 31, 2014. That analytic sample was very purposeful because after January 31st, 2014, there were a few major changes due to the Affordable Care Act that may have thrown off some of our analyses. So we stuck to a before time period there, and we created 2, 5, and 10-year cohorts. The outcomes that we're looking at are medical care costs. We look at total, but we did break it down by what was paid by the health plan, what was out of pocket, and we isolated any costs attributable to hearing loss. Inpatient hospitalizations, total days hospitalized, number of readmissions with 30 days within 30 days of discharge, number of emergency department visits, and we also just looked at number of days with at least an outpatient visit. And we came up with this difficult methodologic question about how do you measure hearing loss in the claims data set. And if you look at research in this area, there's been a few different approaches, as simple as throwing one ICD code or throwing all ICD codes. And we took a little bit different of an approach. We were very careful. We used a lot of negative covariates. The problems being that, is coding appropriate from physicians across the board? And, I'm not necessarily talking about ENT. I'm talking about, PCPs, are they coding for hearing loss if they're using the right codes? Capturing hearing aids is difficult because they live mostly outside the insurance system. And there's going to be a ton of undocumented hearing loss. And so we did do a few things where we looked at only adults over 50 years of age because we were trying to get into age-related hearing loss. They couldn't have hearing loss ICD codes 2 years prior to our index date. And we went back as far as possible on everyone involved to make sure that we weren't capturing sort of congenital hearing losses or early adult onset progressive hearing losses. We included codes for hearing loss, like general, unspecified, and sensory neural. We excluded sudden hyperacusis, neuroconductive central hearing losses. We also excluded people with not just same year, but because usually it was much closer than that, but whenever they had in the same year a code related to an ear disease, such as otorrhea or otalgia, or any ear surgery. And what we assumed was that if we saw, a sensory neural hearing loss code, and then a month later, some sort of surgery, most likely the code was wrong and it was a conductive loss. And so we excluded those, assuming that there were errors in coding. And we did do sensitivity analyses to go back and look at everything, and we found similar results, to be honest with you. But we think we got closer to sort of age-related hearing loss with this. We excluded hearing aid use because we don't think we're capturing all hearing aid use. And, when excluding that, we have to make the assumption that there's a lot of hearing aid use in this population. But I do think it's a conservative bias, and I'll explain in a second. We propensity matched those with evident hearing loss to those without any evidence of hearing loss. We matched on 38 variables: insurance type, demographics, census geographic region, education level, comorbidities, office visits, inpatient stays, ED visits, and spending at baseline, as well as major comorbidities not involved in the Charleston Comorbidity Index, like dementia, depression, stroke, breast cancer, including breast, prostate, renal cell, and colorectal at baseline. We use regression analyses, linear for something like cost, and Poisson for count variables like 30-day readmissions. To give you an idea of what our cohort looks like, at 2 years, we have 77,207 adults with hearing loss, and the same without hearing loss. The mean age after matching in those groups was 63.8 and 63.79. I think we did a pretty good job. When we get to the 10-year cohort, which is actually what I'll focus on with the results, that's 10 years of continuous claims on these adults. We have 2,364 in each arm. And the spread gets a little bit wider, but not much wider. The mean age 61.03 and 61.05 with the matching. So the propensity matching did a pretty good job. And after looking at this, when we actually start looking at things like spending, and I'll key you into the 10-year differences. Over a 10-year period, those with evidence of hearing loss spent on average $22,434 more dollars in healthcare spending. And this number barely changes if you start to look at what's attributable to health plan paid, outpatient, and if you remove anything attributed to hearing loss, which we did, it really doesn't change it, because as you know, when we're excluding surgeries and all that's really left is like diagnostic testing, there's really not much going on in terms of spending that's significant here. Over that same 10-year period, adults with hearing loss had 47% increased rate of hospitalization. They spent 2.5 days longer on average during hospital stays, 44% increased risk of 30-day readmission, and a 17% increased risk of ED visits. And a lot of these were very dose dependent over time, meaning that the numbers were growing the longer somebody was followed. So in the 2-year period, for example, just like with these numbers on spending, you only see a $3,852 difference, whereas over the 10-year period, you see a much wider difference. Same thing with these, where we see like a 20% higher risk of readmission in the 2-year period, but as we look over longer, we get 44% increased risk of experiencing that. Most people sort of ask, well, why didn't you look at hearing aid users? Wouldn't that be interesting to estimate the effect of hearing aids? And the problem is, even though, at the bottom there, we note it's almost impossible to really capture hearing aid users and claims data only. It's also just an issue of people with hearing loss who use hearing aids are really different to those with hearing loss who do not use hearing aids. There's income, education, there may be different health-seeking behaviors and perceptions of hearing loss. There's a lot of confounding that happens there and unmeasured residual bias that we would not be able to pull in that would really throw off any estimates. And so we don't feel comfortable making those sort of conclusions, and we didn't feel comfortable sort of putting that out there for people because we were afraid we would overestimate it. But to that point, our team did do something that we think starts to get a little bit closer to those kind of estimates. This is data from the current Medicare beneficiary survey, and we looked at spending over a 1-year period. It's a little over 1 year, but really it's 12 months. We had, I'm blanking on the number in this one. I think this is 10,000 Medicare beneficiaries. And when we look at spending among these we did a sub-analysis of those with hearing loss who used hearing aids that were Medicare beneficiaries. And I think we get about 2,000 or 3,000 Medicare beneficiaries in this study at that point. Those with hearing aids who used hearing care services in the past year actually had reduced Medicare spending. And so in the survey, they actually asked people, did you see an audiologist in the past year? Or did you see I think they used like a hearing loss specialist. They used some sort of vague term as well in addition to audiologist. And when we looked at that group specifically, we saw $2,513 less spending. So savings, really. And our assumption was really that we're starting to isolate a group that is relatively homogeneous in that they're all hearing aid users. They've accessed hearing aids. So, for whatever reason, higher income, better access, better insurance, better Medicare Advantage plans, regional differences. This group does have hearing aids. And then those who actually go and see somebody are doing better with overall healthcare engagement. And we thought that was a nice sign. And I think there's a lot less bias in that group and the differences between those folks because they've already accessed the system. Next area that we really want to focus in on, that I wanted to focus in on, was satisfaction. A lot of people think, well, why do we care about satisfaction? We know satisfaction is very variable among people, and it's true. Satisfaction could be a reflection of something like, you got lime jello instead of orange jello at the hospital and now you're upset. But it also is considered this incredibly important patient-centered mechanism, and it is something that Medicare links reimbursement to via the HCAP surveys. So hospitals are ranked regionally and put into different reimbursement tiers based off of their satisfaction measures. And so we started with, again, a hypothesis that hearing loss will be associated with reduced satisfaction with healthcare, and we believe it's due to via communication barriers. We're using the Medicare Current Beneficiaries Survey, 12,311 US Medicare beneficiaries. It's an interview-conducted survey that does try to take into account hearing and vision in their methods by using placards, by using text-to-speech, speech-to-text, and a few other ways to overcome that, including like video conferencing for those who need it. Satisfaction with care was very, very big picture. How satisfied have you been with the following? Overall quality of healthcare you've received over the past year or since your last reference date. They offer that on a scale of very satisfied, satisfied, dissatisfied, very dissatisfied. We recoded that to a binary by cutting it down the middle. You're either very satisfied, satisfied, dissatisfied, or very dissatisfied. If you know anything about satisfaction research, you actually would know that most people cut it to a binary, and most people actually cut it to a binary at you're either optimally satisfied or you're less than optimally satisfied. And that's because maybe not what we expect, but the majority of people who interact with the healthcare system when we do these surveys say they're optimally satisfied, whether that's a response bias or some sort of survey bias is relatively unknown. But most people are saying, 4 out of 4, 5 out of 5. And so it ends up being sort of you're either all or anything less than. And we did do it that way as well. It doesn't change the results here. We also used ordinal regression. It doesn't change the results. Hearing is defined as functional hearing trouble in the Medicare beneficiary survey. So it's describing your hearing with a hearing aid if applicable. So no trouble, little trouble, a lot of trouble. So there are plenty of people that use a hearing aid and say they have no trouble hearing. In our final data analytic data set, after excluding those with who are missing the outcome of interest that we couldn't use imputation on, we have 11,447, relatively low missing, to be honest with you. Among those with no trouble hearing loss, 3.1% were dissatisfied with their care. Among those with a little trouble hearing loss, 4.6%, and those with a lot of trouble hearing, 6.5%. And I do present the weighted numbers if you're interested. This survey is designed to be representative of the entire Medicare population, and so the weighted representative sample here would be 48.5 million. And after adjusting for confounders based off of an Anderson-A-Day health utilization framework, usual source of care, age, sex, race, marriage, education, income, general health status compared to others your same age, ADLs, IDLs, and a comorbidity count, those with a lot of trouble hearing had 77% higher odds of saying they were dissatisfied with care relative to those with no trouble. And those with a little trouble had 50% higher odds. And I think that's actually a little bit striking in that we actually, if you look into the satisfaction literature, and a lot of people have used the current Medicare beneficiary survey, these are actually relatively high odds compared to other risk factors. We usually find something much, much lower where the difference is not this sort of large and the size effect is not this large in coefficient. But the problem is that is self-report data. And so there's the same source bias in that it's self-report hearing and self-report satisfaction with care from the same person. So we did look for objectively measured data, and we didn't have a lot, but we did find some in one of our studies. In the Atherosclerosis Risk and Communities Visit 5 study, we had a pilot in Washington County, Maryland, and we had 256 participants aged 67 to 89 years of age, very homogeneous, all white population, who had objective pure tone audiometry done in a booth that was calibrated, and they had that same sort of similar satisfaction question. How satisfied are you with the quality of the care you've received from your healthcare providers over the past 12 months? In this one, we did do what is traditional. You're either optimally satisfied, very satisfied, or less than optimally satisfied, somewhat dissatisfied, very dissatisfied. Use 4 frequency pure tone audio average for our pure tone audiometry. We looked at it continuously and categorically according to World Health Organization limits. We use a logistic regression model adjusted for age, sex, cognition in this case as well. And we have a very deep neurocognitive test battery. I think it's 11 tests. It takes about 2.5 hours actually. And so we use the overall global score from that, so our Z-scores that were adjusted. Comorbidity count, diabetes, hypertension, myocardial infarction, asthma, cancer, stroke, and having a hospital stay in the past year as a sign of being relatively unhealthy compared to others the same age. This is not as robust, I noticed probably, as a list of confounders as the last study, and that's because 1, this is a much smaller sample, and 2, we just didn't have the same amount of data in this pilot group. And what we actually found was an interesting interaction between age and audiometry results. And interactions are sometimes kind of hard to interpret, so I'll pull out the, using our probabilities, the point estimates. For a 75-year-old participant in that study, every 10 decibel increase in 4 frequency pure tone average, the odds of being less than optimally satisfied really didn't change, right? We have 0.94 change in odds, so nothing's happening there. But for an 85-year-old participant, for every 10 dB increase in hearing loss in the 4 frequency pure tone average, the odds of being less satisfied increased by about 33%. That confidence interval does cross 0, but it barely crosses 0, and it's still relatively tight. So we're not making any strict conclusions off of this data, but we do think it hints at a real interaction where hearing loss has a differential effect in different age groups. And what I mean by that is that a 85-year-old may have less cognitive reserve, and hearing loss is playing a very different role in that they have trouble compensating for that hearing loss in healthcare settings, and engaging with healthcare. And it has sort of a more profound effect. And I think this is something we might want to keep in mind in future research, that, even though you have the same peripherally measured hearing loss, it may not affect the same two people the same way. And I think it's something that we have to do a better job of accounting for in our interactions and in our modification strata in our models. And the last area in the epi side that I want to present of this work that's laying the foundation for where we're going with the next aims of the K23 is modified help-seeking behavior. I think this is an area that actually hasn't got much attention. And the theory behind this box that we didn't usually have in our conceptual framework, and the first version of this that we submitted for publication did not have, and then the current version does. We actually think that over time, changes in help-seeking behavior would occur if you're, if you go to the hospital and you have a bad experience, or you feel like you had a bad experience, and you ended up, less than optimally satisfied, or you ended up having a 30-day readmission because you didn't understand your treatment and you were back in because you didn't follow it well. And you start to put that blame on the doctors, or you think that doctors can't do anything. It's going to change how you act in the future. And so a lot of this is very compounding and sort of a snowball effect over time. And what we think sort of happens is that someone may start out sort of just very, very, very on the fringes of having sort of different healthcare outcomes. And then something triggers a switch in the way that they start to ignore their preventative care. And they end up sort of downward spiraling and snowballing into, what we would call either preventable hospitalizations or catastrophic hospitalizations that cost a lot of money. And those are the things that we think are driving these major differences. And we're just scratching the surface of this, and I included 2 studies here about this area, but there's actually a few more that were very recently published that I'll sort of orally just mention, and I'm happy to send them out if anybody would like to read them. The first one was by a trainee of mine. Haley Lin is a otolaryngology resident in Taiwan actually now, and she came to Hopkins to do an MPH. And she did this wonderful study where she looked at, again, in the Medicare current beneficiary survey, just some help-seeking attitudes. And specifically, do you do anything to avoid seeing the doctor? Do you delay seeking care? Do you delay seeing the doctor when you feel sick? Do you feel like you worry about health more than others the same age? And do you keep it to yourself when you feel sick? And you'll notice there's a strong dichotomy there. You have 2 variables that are very much about, do you engage with the healthcare system when you're sick? And then 2 that are just about, how do you feel about your overall health? Do you keep it to yourself? Are you worried more than others? And when fully adjusting for sociodemographic and general health determinants, we see that those with a lot of trouble hearing have 22, and this is actually using Poisson regression with robust variance, so you get a risk ratio instead of an odds ratio, which is actually a little bit more interpretable, to be honest with you, I think. 22% higher risk for those with a lot of trouble hearing, saying that they'll do anything to avoid seeing the doctor. 27% higher risk of that same group saying they delay seeing the doctor when they feel sick. But no real differences when we look at worrying about health more than others the same age, or keeping it to yourself. And we thought this was striking because this sort of threw us off a little bit, but we interpret it as Medicare beneficiaries with trouble hearing are avoiding healthcare interactions, but they don't seem to feel any differently about their health compared to others the same age, and after adjusting for other health variables. There's nothing really going on there where they feel like they're more sick, or they worry more than others, or they keep it to themselves. And I think that's very striking, that when you put the healthcare system involved in the statements, we do find differences. The other area for help seeking that we find is some unmet needs, which may be identifications of help seeking or risk playing out for help seeking behaviors. This was a paper published in Health Affairs last year, again, using the Medicare current beneficiary survey from 2016. And we looked at having a usual source of care not obtaining needed medical care in the past year and not filling a prescription in the past year. And after adjusting for, the same sociodemographic variables, we do find that those with a lot of trouble hearing had almost 50% higher odds of not reporting a usual source of care. And this is actually, I can't tell you how striking this is. I don't know if people are really familiar with this area of research, but there's, the vast majority of it basically is pointing us to extreme poverty being the issue with not having a usual source of care, or language and cultural barriers. Immigration status is usually what's pushing it towards. And so to find something like this that's sort of diffuse across the population and would be involved in engagement and finding a group that has no usual source of care is quite striking. And not having a usual source of care is highly associated with poor long-term health trajectories, not just things like spending, but quite literally mortality. Not obtaining needed medical care, 85% higher odds in the past year for those with a lot of trouble hearing, 60% higher odds for those with a little trouble hearing. Similar findings with not filling a prescription the past year, 55 or 56% higher odds and 44% higher odds. And I will say that in that not obtaining needed medical care, in the paper, we did a sub-analysis to look at why, because they actually asked the groups why. And there were no differences on any of the variables when we looked at them. We do this just descriptively. We're not doing fully adjusted because there's just not enough people to start to fully adjust for this. But there's no real differences in any of them, including cost, except the only thing that we see a change on is there's an actual truly higher number using standard deviations, about 2 standard deviations higher for those with a lot of trouble hearing, saying that they just don't think the doctor can do anything about it. And that, again, is striking, that it's not a wealth issue. It's not an income issue. It's not something that you would expect in that area. It's just this one variable that plays out, that they just don't have sort of faith in the system. And we sort of wonder a lot about that, again, in the help-seeking behavior side. The other 2 studies that we've put out recently are, one on this side specifically showing that adults with hearing loss are less likely to engage in preventative care vaccinations and cancer screenings. And we do think this is a two-way street. We think that there may be, some implicit bias on physicians potentially not recommending some of those for older adults, and we do it for those with hearing loss, and we think that's not necessarily anything malicious. We think it's that, communication barriers exist for those with hearing loss, and there's a lot going on, and visits take longer. The other one is we've put out a study showing that adults with hearing loss have higher odds of experiencing a preventable hospitalization as defined by the Agency for Health Quality Research, AHRQ. And preventable hospitalizations are things that should be treated in the outpatient setting, and you should never be hospitalized for things like COPD, diabetes. And they're very much signs of sort of like either poor help seeking behavior or even just, poor treatment understanding and treatment adherence. And so we've gotten a little bit deeper there. But, what matters to me is, what do we do about this? And there's really not a lot of programs to intervene on hearing loss and screen for hearing loss in the hospital setting. What currently exists is that the majority are passive. If they are active, if you start to dig into the literature, which is really hard to find, it's run by a foreign unit. It's like an audiologist coming over. They're from the outside. The purpose is almost always just for, hey, we're going to identify hearing loss and get people into hearing aids. They use specialized equipment. They label patients. What I mean by that is they'll say things like, oh, this person has hearing loss. Let's write it on their whiteboard and tell people to talk louder. There's a lack of training programs. There's a lack of awareness, and there's just a lack of buy-in. It's not a sustainable model. It doesn't ground itself in any implementation science that would be able to be translated into a sustainable practice. And so we work on the Engaging Healthcare to Address Communications Environments (ENHANCE) program. I actually sat down and thought through this acronym, only to find out later that you can just put words into an online web portal thing, and they'll spit out acronyms. And so I sort of feel like a dummy that this took me days to think of. Our program is simple, though. We screen for hearing loss and admission. It's part of our common procedures. We screen using a self-report metric from the ENHANCE study, which I can go into again a little bit, later if you want to ask questions about. If they don't have hearing loss, we don't do anything. If they have mild hearing loss, we have some signage we put up. And if they have moderate, we do use signage and an amplifier. But a key portion of our study is that we train our staff to think deeply about addressing hearing loss via technology, things like the handheld amplifier, environmental modifications like removing background noise, improving lighting, having pre-prepared placards in the room. But this is the deep one. Ensure things like communication considerations, which I actually believe in my heart of hearts, this is what matters. I don't think that the amplifiers in the hospital setting do that much good. They often are potentially making things worse for people with, age-related hearing loss that's high frequency in nature. And they become a band-aid that people think sort of cure hearing loss because people don't have a good understanding of hearing loss on the outside. And so we spend a lot of time focusing on this in our training components. And we do these trainings twice a year, just generally throughout our system. We do lunch and learns from one of my research assistants that goes around. But on the floors where we've engaged and enacted these, we've done webinars where people actually have to watch the webinar and pass a quiz. We use these kind of signs. You'll notice our signs don't really talk much about hearing loss. They talk about the communication factors that people learned. We put them up behind the bed. They are pink and blue. These are different colors for Hopkins. I had to go before an entire board to get approved to use these kind of colors. We use an amplifier. We use the Sound World Solutions or Super Ear device, the SE9000. I don't find this any different from the traditional sort of pocket talker that everyone knows, except that it's like a fraction of the price because the pocket talker company has sort of a monopolistic hold on hospitals. This is like $40 a pop when you buy them in bulk. And so it's much, much more cost effective. So this program is embedded in the current workflow. There's training. We get buy-in because we've refocused everything about communication, and we focus on making our providers' lives, our nurses and our physicians on these floors, easier. And easier to communicate with their patients. So it has a lot more direct implications. We're not talking about things like getting people into hearing aids, which we do think are important, but we're talking about the direct moment in time of communicating. Self-report hearing loss does minimize training and time too. We've done a feasibility trial, and I'll race through this so we can have a few minutes to talk at the end. But I did want to put all these slides in so I can send this slide deck out. The first feasibility trial was a 3-month period. Just to give you an idea, we had tons of meetings with our Quality Initiative Institute, which is Armstrong, to get approval, our ADA offices, who thought we were sort of replicating what they do already, which is a little bit different because they focus a lot on capital D deaf community ASL user hearing loss for better, which is great, but I think they also need to focus on general hearing loss. We had to go through meetings with aesthetics committees to get approval for colors. We had to talk to administration. We had to find clinical nurse specialists to be our champions. We did lunch and learns before to sort of educate people on what we were doing. 6 lunch and learns prior, 8 lunch and learns during, and we did 16 check-ins with huddles during our 3-month period. So this is very much somebody sort of pushing this program. It's a very what you might call in implementation science, white knight syndrome, where somebody's coming in from the outside and riding in to save the day. But that's because it was just a feasibility trial. 502 screenings over that 3-month period. That was 78% of all admitted per our charge nurse number reports. 41 additional people who were not screened, and that was indicated on our forms that they were not screened because they were either unresponsive or refused or there were time constraints. So we had an almost 85% capture rate of at least either getting a full screening for hearing loss and doing something about it, or at least knowing that there's a reason it wasn't done. I'll just key you into some themes here in that we did a discharge quick interview, really quick questions, and we found that among those who identified as having hearing loss, we had 81 people identifying as moderate hearing loss or greater. The majority are saying that they did have previous communication troubles in hospital stays, not during this current one, but previous. And when we asked if hearing was an issue, 73% of them were saying yes, hearing was an issue. When we asked if they felt like communication was better during their current stay, we had a really high percentage saying, yeah, hearing is better during the current stay. But we also had a relatively high percentage, over 50% of those with no hearing loss saying communication is better during the current stay. And I'll be honest, we attribute that to the fact that our program is very much universally applied. We're not focusing on some band-aid approach that just throws the pocket talker at people with hearing loss. We're focusing on a broad communications approach, and most of those communication pattern changes and accommodations can be applied to everyone. Everybody benefits when you slow down for a minute. Everybody benefits when you look them in the eyes when you speak to them or remove background noise. These are sort of universal. And when we asked if people were satisfied with communication, we had overwhelming people saying yes, they were. Please don't, use these findings as some sort of conclusive evidence. It's really a feasibility trial where we're just looking for signals. And the majority of people at the end of that discharge interview, when asked, would you want to see this in other settings, said yes. We asked the providers also to provide some perspective, and 18 of 18 are either strongly agreeing or agreeing with the statement that this program made it easier to communicate with their patients, and 12 of 18 are saying, I think, looks like we have a number off in there. There's only 18 people in here, so I must have put in, I think 6 is repeated twice there by accident. The majority are saying, 6 are saying that, they were repeating themselves less often during the program. We did find, though, that 4 were noted that they needed more training, or were neutral on that, which we actually think is even though it's relatively small, we think that's really important. We want people to feel like they're well trained. And then the majority also reported to us that they want to see this, pushed throughout our system. We did some open-ended feedback where we got a lot of, this is great. I have a loud voice. People can't hear me. Once they put on headphones, they can hear. Such a wonderful program. It's come in handy. This makes my job easier. I will be honest with you. A problem that we find is that people are talking about the headphones, right? And, we actually don't want to focus on that. We want to change the focus. And so despite heavy effort to focus on communication, we still get a lot of emphasis on the whole program is about headphones. And I think that leaves a lot of work for us to be done, which we're doing right now. Underway right now in our K23 is a parallel stepped cluster trial with Enhance, with the primary outcome being delirium prevention. And so we're doing prospective screening, delirium screening on every single person on 3 floors in our hospital. And we have secondary outcomes like communication perception, utilization patterns, length of stay, readmission rates from those floors. This also plays into that there's just a lot going on with hearing care right now. And there's sort of this conversation around universal adult hearing screenings. There's conversations, there is OTC hearing aids coming. And, it has implications for the hospital consumer assessment of healthcare providers and systems, which is what Medicare uses to reimbursement people. That HCAP survey has 7 questions that are very specifically about communication. And so addressing hearing loss may move the needle on those surveys and could have cost effectiveness by increasing reimbursement rates for the hospital. And so the screening part is a big issue. You may be familiar with the U.S. Preventive Services Task Force recently concluded that there was inconclusive evidence for hearing screening for adults over 50 years in primary care settings. And the major takeaways are that there's not enough information in the target population of interest. Are there gaps in screening in terms of, we do a great job of identifying objective measures of screening and objective hearing loss, but do we actually identify people who will find devices helpful and use them was a deeper question that the report raised. There are harms of of screenings, and the harms of screening are unknown, and many people scoff at that. But what they mean by harm is, are there sort of issues with false positive rates where you're sending people into additional testing that's invasive, it costs money? Are there emotional psychological effects of labeling people? Are there conditions where the disease would not have progressed and not needed treatment? What they're getting at is that there are potential harms in just going through the healthcare system. And there's an unknown impact of treatment, meaning that the report specifically identified we don't know the impact of hearing aids on things like dementia. The other major thing going on right now is the OTC saga, I guess, if you will. This is based out of the 2017 FDA Reauthorization Act. The Food and Drug Administration has released the draft regs for over-the-counter hearing aids, creating a label for OTC as well as a prescriptive label. The final regs are due in July 2022. I'll actually sort of skip over this, but if you want to look back at the slides, essentially you have the two labels, but these are also just controls, really, where there's still traditional categories of the wireless air conduction hearing aids and the self-fitting hearing aids. So an over-the-counter could fall into either of those. It doesn't necessarily have to be self-fitting according to the OTC right now. This could change, and this would trigger some thoughts on where OTC hearing aids fall in the 510K exempt pathway. So if they fell under self-fitting, they might not be exempt, and they might have to actually do that. And then there are some tech specs, basic things from an ANSI CTA report on personal sound amplifiers, permissible self-generated noise at 32 dB, latency less than 15 milliseconds, harmonic distortion less than 5%, frequency response range of 250 to 5,000 hertz, response smoothness, no peaks in a third octave band can exceed 12 dB, and a maximum output of 120 dB SPL when it has an input gain control, so wind volume. These may change, so please don't take these as gospel. These may change because we're in a period where the FDA is now responding to what people responded to their draft regs. These are just the reports from the draft regs. But our next and final step of the K23 is taking Enhance and putting it in a primary clinic. And we have actually established we are establishing right now, we've gotten the space for a booth at the Johns Hopkins Bayview Medical Center, and we have an audiologist team member working there that includes direct-to-consumer devices that are available right now. And we're looking at modifying Enhance for the primary care clinic setting, again, aligning incentives, making sure people want to do it, and then following in a pilot study those who are screened and what they go through when going through sort of that pathway, and where the points of harm are and where the sort of touch points of stress where people don't want to follow up with things. And I'll stop there. We only have a few minutes, but I wanted to I am the worst. I don't use Teams. So when I was trying to close out my PowerPoint, I closed out the entire thing. Sorry, we're Zoom people at Hopkins. We're not as smart as you guys. So with that, I know we have a few minutes for questions, and I apologize for going a little bit long, but I thought it was fun to share some of that new work we're working on.
Thank you so much, Dr. Reed. That's very, very, very research and epidemiology, and pushing these things forward. I'm going to open it up to questions. We do have a few minutes.
And I know it's super early, so I don't expect any questions.
I have one question. First of all, I really enjoyed your presentation, and thank you so much for sharing all of the work that you guys are doing. I was just curious, obviously you're in a large medical center just like we are. And I know that hearing loss is not high on the radar for a lot of our professional colleagues. What was your biggest barrier, or maybe how did you overcome that mindset of not understanding hearing loss and its importance when you first tried to integrate some of the work that you've done in the inpatient setting and now as you move to primary care?
Yeah, so I'll be honest, one of my K23 mentors is Malaz Bustani from Indiana University. And Malaz is a geriatrician who is, quasi-academic, famous for working on implementation science. And he worked with me on our pitch, essentially, to generate the demand for the program. And honestly, we use storytelling. And I will be very frank that you can throw all these details of these wonderful studies that the policy folks want and the scientists want and the administrators want. But when it really boiled down to it, telling my personal story with my friend Scott, for example, was what actually drove people to say, we want your program on our floor. And so this has actually been something that, we have our scientific arm of this, and we do it at a community hospital that Johns Hopkins owns called Bayview, which is about 2 miles from our main campus. But at the main campus, which is super overly complex. We have floors approaching us saying, hey, we saw you present about, your friend here, and I've had other people come in and tell their stories with the healthcare system. My research assistant's mom is actually a nurse with hearing loss who has really, really struggled and actually had to leave her job because she could no longer communicate with patients. And I've had her tell stories. And that has literally been what people email me about. They don't care about any of the numbers I throw at them, but the personal stories connect with them, and they suddenly seem to want our program on their floor. So I think overcoming that barrier is really just a reframing of the way we approach it. And again, we're not approaching it from that idea of, hey, you have a lot of older adults in here who need hearing aids, and hearing aids would be wonderful for them. We don't even talk about that. We really just talk about, isn't it terrible that they're isolated in the hospital and they're not able to communicate with you? And that seems to touch a nerve.
Thank you so much.
I'm so grateful this morning that you guys were willing to let me come talk to you. I appreciate you putting up with me at 7 a.m.
No. We really enjoyed your talk, and we thank you for getting up early and